Good afternoon, everybody, and welcome to the webinar. My name is Frauke Weidans, and I am an internist and intensivist in Edinburgh in the UK. And I'm also the chair of the Early Career Subcommittee at the European Federation of Internal Medicine, and I'll be chairing the webinar this afternoon. Now, the Early Career Group within the European Federation of Internal Medicine was set up with the aim of supporting physicians, internists, as they progress to their first senior role, their first post as a consultant, as a specialist. And we very much aim to support professional and personal development. And part of that, of course, is very much promoting physician well-being. And I guess we've all had a challenging year during the pandemic, and we thought that it would be great to share some experiences on how that's affected our well-being as physicians, as clinicians. Now, I'm going to introduce the rest of our fantastic panel in a minute, but what I'd be keen for everybody to do, for everybody who's joining in this afternoon, we can't see you all because that's the way the software works, but if you could all, maybe if you don't mind, just type your name and where you work and whether you're a resident or an internist in the chat box so that we can get an idea of who you all are. That would be really helpful. And then later on, as we progress, we very much will try and make this as interactive as possible. So you can use the Q&A function to ask us any questions. And we may not get to that straight away, but we will try and address all your questions. So please start introducing yourself in the chat box. And at the same time, I'm going to go round our panel of speakers and ask them to introduce themselves. So maybe Tiffany, if we can start with you, that would be great.
Great. Hi there. Thanks so much for having me here this evening, Frauke, and I'm so pleased to be able to join the rest of this panel here this evening and all of you as the participants today for the webinar. I am originally from the United States. I'm trained as an internal medicine physician, and I currently chair the Council of Early Career Physicians and the American College of Physicians. I'm currently based in the Netherlands, where I'm pursuing my medical license.
Thank you, Tiffany. We'll maybe go to Hans next. Hans, if you would please introduce yourself to the audience, that'd be fantastic.
Yeah, good evening. I don't know if my video is working good. I hope well.
I can't see you yet, but carry on. And oh, there we go. I can see you now. Fantastic.
Okay. And I'm head of the spiritual care of the hospital in Maastricht, and yeah, I'm working here a lot of years, and also during the COVID period, and yeah, may help teams to go on and to deal with all which overcome them. Maybe so far.
Yeah, no, absolutely. Thank you. So we will try and draw on Hans' experience as we go along later on. We will maybe go to Alberto next. The unmuting and switching on and off your camera is going to take a few seconds each time, so please bear with us as we kind of switch between speakers. Alberto.
Here I am. Can you hear me? Great. Okay. My name is Alberto. I'm an internist from Italy. I'm actually working at the Gemelli Hospital of Rome. I've got my specialty degree 2 years ago, and I've used to work in an internal medicine department before COVID. Then we got the pandemic and I've started to work in a COVID ward.
Thank you, Alberto. Gemma next, please.
Hi everyone, I'm Gemma Ortiz. I'm working in Terrassa next to Barcelona, and also I got my specialty degree 2 years ago. And also I was working in a COVID ward, first wave. And hi everyone.
Thank you. Matthias?
Yes, thank you for your introduction, Frauke. My name is Matthias Rasper. I'm from Berlin in Germany. I'm an internist and pneumologist, and I'm the speaker of the German Young Internists since many years, and I'm with EFIM activities, and I love the European spirit of EFIM and of our group. And personally, I'm interested in issues like quality of care and training and all this. So I'm very glad being here, and thank you for your invitation.
Thank you. And last but not least, Eva.
Hi everyone, I'm Eva Ruža. I'm internist endocrinologist from Riga, Latvia, being a part of EFIM community. And now I'm happy to collaborate as a part of the early career group. Thank you and welcome everyone.
Thank you very much, everybody. It's great to have you all here. And what we will try and do in the next hour or so is draw on some of the expertise and experience from Tiffany and Hans, and allow the rest of us to share our experiences and discuss what it's been like and what we have learned. And please, for the delegates, please carry on using the chat box. It's really nice to get to know who's there and what your experience has been. And please also, if you have any specific questions, don't hesitate to use the Q&A function and we will try and get to your questions. Now, to start off with, I can maybe ask Tiffany to share her screen, because we would be quite keen to get an idea as to how the pandemic has affected you. So I'll get Tiffany to just tell you how this is going to work.
Yeah, so I think you can see here the screen, which is live and real-time word cloud. And what we'd like to do is have you go to this website, menti.com, menti.com. You can do that on your phone or on your computer or tablet, whatever device you're on. And then type in that 6-digit code at the top, 694698. You'll be presented with a few boxes there, and I just want you to take a moment and think about how COVID-19 has affected you over the past year. What kinds of words would you use to describe your feelings or experiences? And based on those feelings or experiences, just type a word or a few words into those boxes. And you can fill it in as many times as you want. Click send, and then that word cloud should start filling in. Great, so we're starting to see a few words pop up here. Exhausted, anxiety, stress, running on fumes. Definitely understand that. Digitalization, that's an interesting perspective. Money, death, community, loneliness, weird, sadness, grief. Teamwork. So we sort of have a mixture of some neutral, some potentially negative and positive emotions conveyed here. Telemedicine, lost, isolation, internet. Well, that's what we're doing right now, doing this virtual webinar. Great. And yeah, indeed, stress pops up. I think probably more than one of you have entered that in, because that one really sits prominently in this word cloud. Yeah, so thank you all for filling that out. And certainly this word cloud will remain open throughout our chat, actually. And if you'd like, I can share the web link for this in the chat so you can watch it change over the course of the webinar if you'd like, as people continue to add to it. But yeah, thank you so much. Hopefully we'll be able to touch on some of these things that you've noted in terms of how you feel and what you've been experiencing this past year. as we go through the webinar today. Thank you so much.
Thank you, Tiffany. Yeah, it's really interesting, isn't it? And sometimes when you kind of stop and think what it's really been like and how it's affected you, you notice that maybe over the last few months, you probably haven't stopped and reflected enough. And then suddenly somebody asks you, oh, you know, summarize in 3 words how it's affected you. And it may be, you know, the first time you've really tried to condense it in that way. So we will try and address some of those things as we go along. And I'd maybe start with Tiffany, if that's okay. Mm-hmm. Tiffany, I'd be quite keen to just have a chat with you, because I know that you have a strong interest in physician and clinician well-being and also in clinician mental health. And I'd be quite interested to hear how you became interested in that and what work you have done in the past around this topic.
Yeah, so thanks for asking that. I would say it probably comes from 2 places, predominantly around personal experiences of having had burnout happen from previous jobs. But in addition to that, my interest has also come from actually a more somber topic, which is around physician suicide. I've done some research on that over the last few years with colleagues, in particular because we connected on having experienced the deaths of colleagues in our own physician networks, whether as trainees or in our workplaces, people who had died of suicide, unfortunately. That's where that comes from. But that being said, obviously upstream, there's quite a lot more that we are concerned about in terms of maintaining the well-being of physicians and other clinicians as well, who are frontline workers, and also the general mental health of those workers as well.
And how big a problem do you think this is really? What do you think the scale of the problem is, even before COVID?
Yeah, sure. And certainly there's been a growing volume of literature, I'm sure that many here are aware of, with regards to measuring physician burnout and well-being. Common validated questionnaires that are used to measure burnout seem to estimate, at least in the United States and perhaps in other countries as well, that burnout can influence up to 50% of the working practicing population, not just internists, but other specialties as well. Obviously, there's some variability depending on specialty. Other things that have been measured are things like mental health, such as depression and anxiety as diagnoses or the symptoms of them rather. And so the concern there is that we could be looking at about 1/4 to 1/3 of the population of physicians having depression or anxiety. More literature has been published over this past, let's say, 6 to 9 months or so, trying to evaluate sleep quality, depression symptoms, anxiety symptoms, and other aspects of physician and also, for example, nurse well-being too on the front lines during the COVID pandemic. So I would say before the pandemic, it has already been a challenging issue. But with the pandemic on top of that, I think we're all probably here to discuss this today because of the concerns that we're at higher risk.
And how do you think, or why, I suppose, in what ways has the pandemic amplified the problem?
Yeah, so
it's an obvious question, but it's nice to think about it, I suppose, in a structured way.
Yeah, it's a great question. And I think some of our stories that we'll go through today will touch on some of these things, but certainly there's some unique features of the pandemic, like working with the unknown, right? The nature of having an emerging pandemic that we just don't have a lot of medical knowledge about is something that is certainly a factor. Others are resources, for sure. System resources, such as having sufficient personal protective equipment, having sufficient ventilators to be able to take care of our patients, medications themselves, just having enough people to do the work, to provide the amount of care that's needed to respond to the surge of patient cases with COVID, I think also factors in. So there are a variety of system factors, I think, that influence this.
Mm-hmm. Okay, and from your understanding of the literature, but also from your personal experience, what do you think the the kind of warning signs are? How does it manifest? You know, if you're looking out for problems in ourselves and in our colleagues, what are the things we need to look out for?
Yeah, that's a really an important question to ask. And I think it's something that maybe we do much better in looking out for our patients than we do for ourselves or each other, is sort of thinking about what we need. And that need can be tangible or intangible, right? If what we need is to pause and to grieve for a patient who has suddenly died, or to pause and to listen to that voice inside your head to sort of say, what is it that you need? You need to just take a break. You need to rest. You need to, you know, talk out your story or what's bothering you with someone. I think those things are very important cues that we need to pay attention to. That's not to say this is all on an individual, of course, that's never the case, but that there are things to pay attention to and listen to.
Okay, and I'm sure we'll come to kind of some of the strategies on how to deal with issues later on, but again, from your understanding of the literature, what would you say the main strategies are that we can use to promote our well-being in times of stress?
Sure, yeah. I mean, this is some of it, is the sort of sharing, which we're doing today. Storytelling has its role, actually, in promoting well-being, and that has been studied and it has been published about. Obviously, there are system factors like things like, you know, reducing administrative burdens with using and documenting in electronic health records. I think that's probably something that's very vogue topic to talk about and extremely relevant even prior to the pandemic. And making sure that we're minimizing those kinds of unnecessary burdens on our time. Yeah, and other demands that are really things that can be handled in other ways and make our work more efficient. Being able to have decision autonomy is also a really important part. So this feeling of making sure that your work is not dictated by some external force. That's certainly something that has been expressed as a challenge and may vary depending on the kind of healthcare system that you work in. From my past work in the United States, certainly there are external factors that are quite unique that do contribute to that sort of burden as well, with regards to insurance, working against insurance companies and things like that. So there are a variety of things that can be approached as possible factors to address in terms of improving the situation for physician well-being, of course.
Okay, thank you. So I'll maybe come back to you as we go through the individual stories later on and just kind of draw on your expertise to see what your thoughts are. What I'd be quite keen to do, if we can get the tech support to just show us the first poll, because I'd be quite keen for the audience to let us know what they think the challenges have been for them. So you can choose as many as are relevant, but in your personal experience of the following, what do you think has been most challenging during the pandemic? And we'll give you a minute or two to just look at this and think about it and take all the ones that you've found particularly challenging. I don't know if it's too early to show any of the results yet. I'll maybe give you another 10, 20 seconds. Oh, there we go. Okay, so, gosh, that's really interesting. So the highest is the information overload, which is interesting, and I'm sure we'll get to that later on, because certainly in my experience, there were kind of almost two extremes, you know, dealing with uncertainty and having to deal with something you know nothing about, and then followed by information overload. Dealing with a new disease, yeah, anxiety about your own health, having to make difficult decisions or rationing treatment, unmanageable workload quite high, so that's the second highest, and also the challenges in communicating with relatives. Okay, interesting. So clearly quite a lot of difficult stuff there, and I'm sure we will touch on some of that as we go along and go through the individual stories. I'd maybe bring in Hans at this stage, if that's okay with you, Hans. So I know that throughout the pandemic, you have worked really hard to support clinicians in your own hospital, maybe so that the delegates understand what your role is. Why don't you tell us a little bit more about what your role is in terms of before the pandemic and how that's changed during the pandemic, and what you have done in terms of working with your teams. We'll start off with that.
Mm-hmm. Yes, thanks for your question. My normal role is guiding patients and family in crisis. So often I get a phone when someone died. Very sudden. We didn't see that happen. And through the years, I specialized more and more to palliative children, and also the ethical questions. But through the years, what I saw is more and more in this crisis situations is that the own beliefs and values from patients, from family, but also from all caregivers involved play a very big role. And often differences come up in that values, but we don't talk very much about that. So in that line, before COVID already, I began a study to moral distress on the yard, and also how we can lower moral distress in a multidisciplinary team. There are factors which fascinate me as a spiritual caregiver, because I'm then looking more internal, what happens in the person self and what happens in the interaction. And often it isn't really clear what good care is. And sure, when there's a lot of uncertainty, it's not really clear what is good care in this certain situation for this patient. And not only medical answers are needed, but also answers on values, on beliefs, on what find we together important in this situation. So you have a few factors.
Yeah, so from your experience, what the teams you have worked with, what have they found most challenging, would you say?
You know, maybe if I may, I will give. Yeah, I'm just wondering. I will give one example.
Mm-hmm.
Now, one thing where the nurses, but also doctors, what was very difficult is to balance the two values of safety and humanity, because those two values came in conflict. And what do I mean with it? The family of patients, did we let them in the hospital or not?
Mm-hmm.
And what did we do when the patient was dying? Did we then let them in or not? And how much family members do we let in? We still have that problems. And I saw that some team members found safety very important. So they had problem. They experienced moral distress seeing other colleagues to let family members in. On the other hand, there were a lot of colleagues who found humanity very important, and they let family members in, and they experienced moral distress because they saw other colleagues which didn't do that. And yeah, we lost a bit our structure. So, we also had differences between different yards.
So that's quite interesting. So in many ways, you know, individual clinicians will have been affected by, say, the anxiety around their own health, or others more because they felt they couldn't provide the holistic care they would want to provide. But at the same time, did you feel that because individuals reacted to that differently and maybe have slightly different values, that then affected the teamwork as well? Is that what you're saying?
Yes, that your values, surely in an emotional, stressing situation, your values will always play up. And some of us in stressing situation will get very very quiet, and they can handle it very good. And other colleagues will get a lot of stress. So our dealing with stress is very personal and has a lot of is connected very close with our life stories. And the question is, do we see them enough to handle them, but also in a team where we have to work to also discuss the differences. Is it clear enough?
No, absolutely. So why don't you share with us then some of the things that you've used in your hospital to give the individual clinicians and the teams the opportunity to discuss the issues and hopefully make it easier for them to deal with?
We had in the first wave, we had 3 times a day after the handover, we had a debriefing for the team which went home then. And it was free to come or not to come. I think that's very important that you can choose your own. When you're very tired, go home and don't come to the debriefing. But when you think I had a patient, I had a situation which was so overwhelming that it's good to share it, then come to the debriefing. So it was open, it was open to come.
And were they facilitated? But were they facilitated by yourself, or was it just informal peer-to-peer debrief?
No, they were facilitated to my team. Because we did it really always. Also my team members, we always, one of us slept also in the hospital, so that if there are situations where the other members wanted help, it was possible to get. Because we saw a lot of the difficult communication situations, a lot of existential situations. Because one part of my job is to focus on existential questions, so we can't answer rationality. But one thing of COVID was that we lost control. So, and that creates another need of communication than we are used to.
So essentially, either yourself or one of your team would have been available anytime, day or night, if there was a difficult situation for a staff member or a difficult conversation with a family. You would be there to help and support.
Yes. Yeah.
Okay. And what feedback did you get on the debriefing sessions, but also on being available on call to support the teams?
what we heard is that it's very useful to help each other. You know, maybe if I may, I go back to the words which Tiffany showed us. And when I look at that verse, what you then see is that meaning making is a very important aspect. And you see two different possibilities: a negative meaning making or positive meaning making. That's the first question we ask ourselves when we try to find meaning. And the second question we ask when we try to find meaning is, is what happens? Is it something which overcomes me, or is it something which is my responsibility? And if you look, if we would look back to the words we have shared, you could group them on those four aspects. But it makes a very big difference which meaning you gave. When, as an example, when you couldn't save the life of a patient which had COVID, but and that another aspect is expectation, and you expect from yourself that you should, that at the doctor you should have to do that. You will feel guilty, because then you self think I must manage it, but you can't. But the question is, do you see that it's also something which overcomes you? Then you can share it with a family. But that will get a totally other feeling in that situation. Than thinking that you have to manage wholly the situation.
Yeah.
Yeah.
And but did you think it was easy for all clinicians to approach it from a slightly different way and communicate with the families on that level, and share, I suppose, your the emotional aspect more than the technical aspect of dealing with the disease?
What I saw is that it was very, very difficult. It was very, very difficult because everyone was searching, and because surely in the first beginnings we also didn't know good how how big the risks are for ourselves. So you are more likely then to go in own emotions than when you have more a grip on the risk for yourself. And the combination of it made communication very, very difficult. Also, that often communication went through the phone. Yeah. So you miss all your non-verbal communication. But surely when the themes are more heavy, when you have to talk about what shall we take someone on the ICU or not, and shall he die then? Then normally it's very important to also can use your non-verbal skills. So it was a lot more difficult. Maybe I can tell an example. We had one patient far in the 80s for years, and we all wondered because we thought he would die, but he didn't. And it was a story which gave us hope, which gave all the team members hope. But a certain, I guess, 1 week, 1.5 weeks after that moment where we first thought he would die, he get so tired that he himself began to talk with the doctor that he couldn't go on. Yeah, so he was sedated, and the oxygen was taken away, and he died very hard, very quick. Yeah, but the doctor which guided it, and he speak very well with that person, so it was very good, but still had the feeling, oh, I let him die.
Yeah, it's hard.
And that situations we talk together in the debriefing, and then also colleagues can say, but you did it very well. You made a decision together with the patient, and it's not your fault that it was over.
And did you have anything in place to support clinicians in making these decisions? Was there, say, an arrangement to try and make these decisions as a team rather than an individual person making these decisions, or?
Yeah, do it not alone.
Yeah.
When we're sharing, you can always, you have the possibility to ask each other, am I seeing it good? And surely in a situation with a lot of uncertainty, it's very helpful to share your thoughts with colleagues.
Yeah.
We also have here an ethical commission. So the very hard cases we also discussed in that ethical commission, and then you must think it's about doctors, nurses, but also how do you call it, the advocates, jurists, etiquette. I myself or someone at my team is sitting in the commission. Because when the uncertainty gets very high, it's a very big help, I guess, to share it with each other, and then try to find every evidence you can get, and then make the decision together
as a team. Yeah, absolutely.
As a team.
Yeah, I'm just looking at a question that Ivas has put into the Q&A box, and I don't know if you witnessed any of these issues as well, Hans. So I guess sometimes the anxiety and the uncertainty can lead to conflict between different clinicians as well. So Ivas is saying that he was working in the COVID department and he was asking for consultation from a different specialist, for one of his patients, and that specialist essentially refused to come and see the patient. I mean, I obviously don't know the background, but that may well be because that particular person wasn't working on a COVID ward, and maybe then sometimes the anxiety is even worse when you haven't been involved yet. Have you experienced any conflict between professionals as well that was maybe triggered or exacerbated by the stress that everybody was under?
Yes, yeah, sure. Maybe if I may, a bit broader. Every medical discipline has its own values and convictions, and there are always difference. And I guess many of us know the internists are more reflective, but there are other colleagues which are less reflective. I will not tell who, but and in a normal situations that also get sometimes get I don't know the word, but it's in a normal situation this can get hard. But with the pressure of COVID, that went worse. So one example, the youngest patient which died here in the hospital was somewhere a bit more than 40 years. And we had a lot of discussions between the intensivists and the internal doctors, because the intensivists, and they discussed him 2 or 3 times, because also found that decision very, very heavy, but they were convinced that they couldn't help him. So, but the internists found it very hard to not give that patient the chance to go to the ICU. So, and what we finally did is that we took him off the yard where he was laying, because of that we could give him the possibility, and we could give his wife and his young children the possibility to be with them when he died. And that during the first wave it would not have been possible on the ICU, because there was the pressure was too high and the chaos too much. So that was the way we found. But it's very hard. I know, I still remember, it's very hard for both doctor groups. Yeah, because everyone is trying his best for the patient. An intrinsic motivation on a care between caregivers is very high, but also risky.
Yeah. Yeah.
Sorry.
Interesting. Yeah. But yeah, I mean, it certainly sounds to me like the teams in your hospital were very lucky to have support from you and the rest of your team to, to support them, and to also, I suppose, almost mediate between the different specialists if there was a problem. I'll maybe ask the tech support to show us the next poll, if that's okay, because I'd be quite interested to see what support, well, whether you guys have had any support at all. So if you can, there you go. So during the pandemic, were you offered any additional support at work? So anything that wouldn't normally be available to support you before COVID, was there any new additional support? And I'll just get you all to think about it and answer it for us. And in the meantime, please feel free to put your questions into the Q&A, and we will, if we can't address them straight away, we'll try and get back to them later. So okay, so actually some people did, 36% did get additional support. Well, I suppose that's a third. And why don't we go straight to the next poll just to see what support you were offered? Okay, so if you just, anything that you had access to, if you tick that and share it with us so that we know, we can see what support was in place for you at your workplace. Okay, let's see some results, if you may. So that's very interesting. So people do feel that they've had additional support, but actually it looks like most of it was kind of clinical decision making or technical support, so presumably guidelines or protocols on how to deal with COVID. And only 17% had access to formal or facilitated debriefs. 17% again had access to counselling, which is, I suppose, not very high. That is interesting. Yeah. What are your thoughts on that, Hans? Disappointing? Surprising?
I don't find it surprising. I find it, I find it a bit sad,
Yeah.
but not surprising. My own experience is that sharing your emotions and sharing your searching, your not wondering, not sure knowing, is not common in hospital care.
Yeah.
Here, and I find that very sad here, because we are also only human, and it's good caring for yourself and for others.
Okay. Yeah. Thanks. I would be quite keen to ask Alberto to share his experience, if that's okay, because I know, Alberto, that you were working on a COVID ward quite early on, and I think it would be quite interesting for people to hear what that was like.
So I'm still working in a COVID ward. You know that in Italy now we are facing the second wave of the coronavirus, but I can say that it's completely different from the first one, basically because at March everything was completely new. So given the high inflow of patients in my hospital, it was decided to suddenly open several new COVID wards. And I was commissioned to work in one of those departments since last March, and in fact to be one of the team leaders of those departments. And I remember that the first week in particular was very difficult, really like a front line. There were several factors that made that week so complicated. First of all, I remember that the admissions of patients was so massive that just in one night, the same ward was completely full of patients. And for basically the first time, we started managing a patient that was completely isolated. So they were in a respiratory isolation, and we started using the PPE. And we were not familiar to use those PPE. I mean, we had several preparation courses, but one thing is to be prepared to know how to use them. Another thing is to wearing PPEs for several hours, for a half day. And at that time, basically there were no evidence-based therapies, no guidelines, or I mean, better to say that there were guidelines, but the guidelines were updated every day or every 2 days. And so we were overwhelmed by info and through every kind of channel, obviously. And moreover, I would say that this is really personal because that was my first experience as a team leader. Even if the team was quite small with 8 colleagues, it was a multidisciplinary team with senior colleagues too. There were 4 residents and 4 consultants. And so basically I tried to do my best, and I tried to stay in hospital as much as possible in order to understand how the patients were doing and how we were behaving as a team. And that is why I remember that the first week was a sort of never-ending shift. And we had meetings after meetings at any time of day or night. And that was quite tough.
Yeah. It sounds a bit like you were looking after the team more than you were looking after yourself, maybe.
Well, I could say that probably during the first week, yeah, that was my aim. I mean, I was commissioned to lead the team. I tried to carry on. I mean, after that point, after the first 7 or 10 days, I think that something changed, and also because the entire team recognized my leadership. That means that I was not there for imposing anything, but just for supporting them, and that was important as well. And then we started to be used to the environment, to all the difficulties that we had in the world, obviously. And so things then went a bit better.
So from your experience, what did you learn? What were the things that made it easier for you and the team to deal with the stress?
For sure, I mean, when we really understood the real workload, and so that we know how to divide all the shifts, I mean, to make a real shift schedule for every one of us, that was the real turning point, because we could have hours also for resting outside the hospital, and to think what we was doing and try to metabolize everything. That was the real turning point.
Yeah. Okay. I don't know if you can maybe get some reflections from Hans and then from Tiffany on what Alberto's been sharing. That'd be quite nice. Maybe start with Tiffany, actually, if that's okay. What are your thoughts?
Yeah, I mean, I think, you know, when I think about the situation that you describe, Alberto, there's this particular model of thinking about the kinds of demands and the resources you have available. Job demands and resources model is basically what it is. And when you talk about how different it was between March and now, the first peak and the second peak, the demands and your resources are quite different, which may be why you feel different about how things are going now in the COVID ward. Demands usually are things like psychological, emotional, quantitative demands, you know, how emotionally prepared you are for those kinds of situations, and the workload that's required to be able to take care of very, very sick patients with a very information poor scenario. And that information poorness that you know, speaks to less resources that you have, the skills to be able to take care of such a sick patient with an emerging infectious disease. And that balance, just I think, with the pandemic significantly shifted that towards much greater demands than there are resources to be able to respond. But now I think we are fortunate to have this gift of hindsight to be able to have learned so much, and to be in a better place, not necessarily ideal still, of course, for many reasons. But I think as a global society and economy and community in medicine, I think we're shifting towards a better balance, and hopefully we'll get there sometime in the next months.
Hans, any comments at all on what Alberto has been sharing with us?
I hear two themes. One theme is expectation. In the beginning of the crisis, we didn't know what we had to expect. We hear near this hospital, we built a second hospital we never used. But a lot of work was placed in that. So the expectations become more clear, and that helps. So we get back a bit of forecasting. And the second I heard is structure. With that enormous number of patients, we had to leave our normal structures because we couldn't handle them. But when at the moment that works at time, but we all need a structure, because it guides us through the weeks, through the day. So rebuilding a structure, that is what I also hear in Alberta's words.
Yeah, interesting. Yeah, I remember that myself actually at the start. You felt almost lost, partly because there was part of the uncertainty, and because the ways of working were so different, that you just, everything required more thinking and more effort, and you didn't have the normal structures. Absolutely. Gemma, I would like to come to you next. If you don't mind telling us a little bit about what you found particularly challenging, because I know that you certainly had to deal with a lot of COVID activity as well.
Yeah, thanks, Frauke. Well, one of the main problems we had, I had, was the communication with relatives. Under my point of view, I think that there are two main problems. One was the way it has to be done through a phone call, and also the small knowledge we had about the disease. Well, any kind of information was through the phone, what implies we lose our nonverbal communication skills, as Hans has told us. But also I felt unable to moderate the conversation, the way it has to be done. So I am sure that it generates a lot of uncertainty within the relatives. And of course, everything was magnified, the good and the bad news, and especially the bad ones, but also with the lack of visiting. And in the other hand, we had the lack of knowledge about the disease, the short and medium-term consequences, and the eventual evolution of the patients. That made everything more difficult to give firm explanations to the relative, and growing their uncertainty. Maybe at the beginning, I tried to communicate just clinical data, temperature, saturation, need of oxygen or not, but it didn't work at the end. So it was really difficult to manage.
And what did you learn from that? Is there anything that you did differently later on?
Yeah, I learned to give the information the relative need at that time, because they tend to ask questions and not just listen, and they wanted to know just certain things, and if I asked what they were asking, it was easier.
Mm-hmm. Okay. And did you use any other technologies like video calling or FaceTiming or anything like that at all to make it a little bit easier?
Yeah, well, at the beginning, no, because we didn't have the things to do it. But at the end, we learned how to use technologies. We did video calls, not only with the relative, but also the relative with our patients. And it was really useful because they could see how they were looking and their aspect, and if they were good or bad, beyond what we were telling them. So it was useful. And also we start giving the information through every 48 hours, which was much more easier for them, because if they didn't receive the phone call, that means that it was going okay and their stress was low.
Mm-hmm. Yeah. I mean, we used video diaries as well as lots of telephone updates. And I definitely felt that the videos helped a little bit, because it seemed to be much more difficult to build up trust with the relatives. I mean, normally, certainly in our intensive care unit, the relatives would be there pretty much all the time, and they would at least be reassured that there is a nurse by the patient's bedside all the time, and they would see and observe and appreciate all the care that was being delivered. Whereas when they're at home, not able to visit, then they just weren't able to appreciate that. And I think often that they would be at home thinking that their relative, you know, was left abandoned in the hospital and nobody was caring for them. And I think it's quite difficult to convey the amount of care that's being given, you know, with a telephone call every couple of days. Did you allow relatives to visit at all during the first wave, Gemma?
It depends. It's a difficult question to ask, but it depends, because some relative really needed to see how our patients were going. Even we had video conferences, or every 48 or every day phone calls. They really needed to see it, even it was good or it was bad. So I let some relative to visit their families, just to make sure they were in peace, themselves and the patient.
Yeah. I mean, for me, probably not having normal visiting was probably the hardest, almost the hardest bit during the pandemic. And I think actually, particularly for our nursing staff, it was very hard, because they're obviously used, when they're delivering end of life care, of having visitors and relatives there, and they found it very challenging. I don't know if you noticed that as well.
Yeah, I did as well.
Okay. I don't know if Hans has any comments on what the strategies are that could help in that situation when the communication is so much more difficult and we can't rely on face-to-face conversations.
Yeah, Frauke, you used a brilliant sentence in what you said, and that is build up trust. And I get that's the most difficult thing in uncertainty. You can't help family with rational information, even if they ask, then give the information, but they can't manage the information. So that is what I often see on the ICU. But the building up trust, let them feel we will care, but we also don't know. But we will walk together step by step, and we will see. We try to save the life, but if we don't succeed, we will we will do our best that someone don't suffer. You know, I get that there you need more in an uncertain situation. You need more emotional communication than rational communication, and maybe one step more. Men are more used to rational coping, so that is what you often will see, and women show more emotional coping. But also men, you can't help them very good with the rational information.
Yeah, Yeva's got a question, I think.
My question was for Alberto, knowing that you have a small child and now suddenly needed to deal with being leader and creating new team and being there for much more longer time than expected. How did your family felt about this? How did you see that you are missing or being away from the family?
Yeah, thank you for your question, Yeva. And sorry, but my son is trying to enter the room, so if you are hearing
we don't mind, you can join.
Sorry. Well, actually, you know, as I said, when the pandemic started, everything was new, and we didn't know anything, even if we could carry home the virus itself. But you know, I took one decision, and the decision was that I cannot live with fear. I mean, I have only one family, my young wife and my young son, and of course I want to do my job. I also do not want to lose them with not seeing them for months. So it was a choice, but I think that it was a rational choice.
You can just ask Eva, you don't need to
Oh,
ask my
okay.
permission. Just put your hand up and speak.
Yeah, I didn't know that if we need to brought into the room somehow. I had another question probably for both of you, Alberto and Gemma, that we know that, like Eva stated, that many doctors don't want to communicate with this. I will pose this question from different perspective. Did you feel that your friends or relatives denied to see you or meeting you, or did you felt somehow abandoned from your close friends during this work in COVID unit?
Gemma, please go first.
No, well, in my case, I felt very supported by my relatives and also my friends. But what I felt, it was that I didn't want to talk at that time at what was really happening inside me and around me. And that was very tough to talk about, but they tried to support, even saying, we are here and we're here, just whatever you need. So I felt very protected by them.
Yeah, I can say the same. I mean, my family, my parents, and my friends, they have been there. They have been supportive all the time. But I can also say that other people showed a bit of maybe fear of just see me and talking with me just because they know that I was working in and I'm working in a COVID environment. So yeah, many people still supportive. Someone who probably because of fear is a bit I can say cold with me. Yeah.
Okay, thank you. Tiffany, I don't know if you've got any comments or reflections on what Gemma and Alberto have been talking about.
I think what I'm hearing is about this isolation aspect, which I think somebody had entered into that word cloud earlier as well. I mean, and that isolation comes from various perspectives, right? There's the patient who's isolated from their family, you who are isolated from your own friends or family socially outside of the workplace, and various other facets. And I think the pandemic has introduced this need to be very intentional and deliberate to create more connection with anybody around you, whether that's with the patient's family, with your own friends and family, through virtual means or otherwise, to be able to feel connected and less isolated. That's certainly been a significant burden, I think, that a lot of frontline workers are having to face. And I really love hearing Gemma's experience of being able to have people who are there and, you know, they're not gonna, you know, put pressure on you to share, but it's like, we're here for you when you feel ready to share. And I think we could do more of that for each other every day as well. The idea is, you know, when you're ready, when you feel comfortable, that's part of the process, is, you know, just knowing that you have someone who's supportive of you, whether or not you actually share a story, I think can have such profound meaning for someone.
Yeah, that is really interesting, as you say, just knowing that you can share whenever you feel ready. And I don't know what your thoughts are for both Hans and Tiffany. Is it more helpful, I suppose, to share these experiences with colleagues who have had shared experiences and who understand the difficulties and the stresses? Or is it sometimes more helpful to share it with family and friends who may, you know, who will presumably understand the emotional aspects of it, but won't have the same experience of really understanding what it's like?
Yeah, the sharing knows some difficulties. And the one difficulty is when you share with your family, can they handle? And that's one of the difficulties. So the situation you want to share is very important to look what the impact of describing that situation. From my own experience, I sometimes shared with my wife situations which were very heavy about the dying children. Now I don't do that anymore because that's not. It was too heavy to share. So that I now share with the doctors and nurses involved here because we saw the same. So that's one important question. So what you want to share, is it normal heavy or extra heavy, and look also if the other can handle it. There's a second problem, and the second problem is more difficulty. It's from grief research. You know, we have in sharing, we can do two different things. The one thing is we just want to share our sadness, our grief, our overwhelming, whatever. But we don't want solutions then. Here, you just want that someone listens and that someone says, oh, is it that feeling or is it those feeling? No solutions. So when you're in that mode, you need someone who just listens. But there's another mode dealing with heavy situations, and the other mode is going on, looking forward. What are the solutions? What can we do? Mm-hmm. And then you need someone who is also thinking forward together with you. But when two colleagues are in different modes, you get a problem. Yeah, because mm-hmm. someone who just wants to share his sadness don't want any solutions or whatever, and someone who just who likes to look forward has no need of someone who just wants to share. So that are the two problems. So look for someone who is in the same mode, and look for someone who knows where you are talking about.
Yeah, I would 100% agree and echo what Hans just said. It can be very, very jarring for people who don't know these experiences or images to share the details of the experience. And I would also add, in terms of the possibilities of sharing, the one option that physicians and clinicians are probably quite guilty of not drawing upon is actually professional help, which is incredibly important, I think, as an option in terms of being able to speak about very difficult situations that an individual may have difficulty processing to a third party, to somebody who can sort of professionally guide you through the processing of a particular difficult situation through that reflection and that need to be able to be compassionate towards yourself, to recognize that your feelings and your emotions and experiences for something quite difficult can in fact be quite normal. You are a normal human being in very abnormal circumstances. And sometimes an outside perspective from someone you don't know, but who is professionally trained to be able to help, can be extremely valuable. I think the challenge that we face as clinicians and physicians in general is the stigma around help seeking and what its potential consequences may be, for example, for your credentialing or your licensing, your reputation. And those are very hard barriers to overcome, but incredibly important, I think, when you're thinking about solutions from a systemic perspective. I totally agree with Hans that, you know, if you're not in the right mode on an individual level, solutions, you know, they will not work, and they will not sort of hit the right tone in terms of being there for someone. But from a systems level, it's incredibly important to try to build systems that permit help seeking when someone feels that they need help.
Yeah, I couldn't agree more, actually. Do you think, both of you, maybe Hans and Tiffany, do you think clinicians found it easier to seek help or to, I suppose, express vulnerability during the pandemic, or more difficult? Because my experience was that actually, because everybody knew how stressful it was, it seemed to be more acceptable to talk about stress and difficulties of coping with the situation, and clinician mental health was more openly discussed than it usually is. But I don't know if that's just my experience in my workplace.
It's also my experience, but what we saw is in the very beginning, there was there was more sharing, but after a few weeks, all went back to normal mode. that is what we saw. So and then the sharing also stopped. But what we see now is because it gets longer and longer and longer, that we came now in a new period, and with new challenges, and I guess that sharing now becomes again more important. But we meet that barriers which Tiffany described. So that's my experience.
Yeah, I think I would say anecdotally also that it would seem that sharing seems to be more acceptable, and the temporary need to seek help is more recognizable. I just hope that the efforts that have begun to try to overcome those challenges and barriers are things that are sustainable, or sustained rather, long into the future. So, you know, I believe in one of the question poll responses was that some people had access to, for example, a telephone advice line. That is indeed a very popular method. And I know that, for example, in the US, there was a female psychiatrist who started a sort of large group of volunteer psychiatrists across the country to offer a confidential, free call-in, toll-free call-in line for any physician who felt like they needed to talk through something, by medical doctors trained in psychiatry. But and that's a wonderful service that's still ongoing, of course.
Absolutely, but why does it take a pandemic to have access to something like that?
Right. Why isn't it something that's a volunteer service that only pops up during a pandemic? And why is it not something that is more readily available in general and funded to continue? And I think these are very important questions to ask of our health systems, and the policies that drive funding for these kinds of resources. I think it's no surprise to any of us that probably most countries, or all countries, are really underfunded when it comes to mental health in general. And that, of course, includes mental health of everyone, including physicians and clinicians.
Maybe because when I listen to you, Tiffany, maybe I may numb some underlying problem. Now, I guess the medical view is a very individual view, but supporting each other is a social business. And maybe we look also to mental problems too individual, because the strength is often in the support of the group and not only in the individual strengths of the team members.
Yep, it's the classic biomedical model versus the biopsychosocial model, which accounts for much more than just you and your physiology and your experience. It's everything else around you as well.
Now I'm just watching the time. We'd planned kind of up to 90 minutes, so we are rapidly running out of time. I'd be quite keen to ask Matthias to share his view on what the challenges were and what he's taken from his experiences actually, and then move on to Eva after that.
Yes, thank you, Frauke, for giving me some time to present my view. I haven't worked a lot with COVID patients, just in some 24-hour shifts, because I work in an outpatient clinic in hospital. And what I experienced was more the side that other patients maybe receive worse care during the pandemic, so that there is like a collateral damage to other patients. And in our hospital, or in my outpatient clinic, for example, Juli, ich kann nicht. Nein. Sorry, my son. We experienced, or we had to discuss with patients to maybe not do adjuvant chemotherapy for lung cancer patients, and not to put them in danger if they get add-on while being immunosuppressed, like the COVID infection. And we had problems with the relatives because they were not allowed joining the talks in our ambulance, and that was upsetting many of our patients a lot. And we tried to get the relatives on phone and all this stuff, but we had a lot of discussions there. And maybe if I have the time, it just take me a few seconds. Regarding the resources we have for traumatized colleagues in our system. We just had last year, before the pandemic, a little survey within our society in Germany. And it was about the second victim phenomenon, which means that healthcare professionals can get, and which is frequent, traumatized by unanticipated events or severe events in patient care. And we have no structures in Germany to take care of these colleagues. And we saw that from 550 around participants, around like 60% had experiences or experienced traumatic events, even without COVID-19 in their career so far. And it can have a huge impact on them. Like they can deliver worse care because they cannot concentrate maybe anymore, or their work, they behave very defensively in patient care or stuff like this. So I think it's now even more obvious that we have to do, like Tiffany and Hans said, that we have to do more for traumatized patients and for our psychological health for healthcare staff.
Yeah, I mean, certainly, I think, I don't know, I'd be quite interested to hear what Gemma and Alberto think. The second victim aspect of it, we talked earlier about the uncertainty in not knowing how to treat the disease, and having to accept that often, when we're dealing with COVID, the outcome is poor. But what Matthias describes, I suppose, is more that because of the circumstances and the lack of resources and the stress the entire system is under, you sometimes find yourself in a situation where you can't deliver good care, not because it's not medically possible or not because you don't understand the treatment, but because the system is under stress and you're under-resourced. And certainly I found that probably the most difficult aspect. I don't know if anybody else wants to comment on that.
Yeah, maybe what I see here at the moment is that because we had normal care stopped for a big part, now it's running on. But the problem is only the very heavy and the actual patients are running on. So it's very hard for all team members because the whole hospital is lying full of patients with very heavy diseases which can't wait, or with COVID. And we have to manage that, I'm afraid, for also a long time. And that combination that you have less patients which are not so severe sick, ill, that gives the more workload. And we have here a lot of discussions about which patient can we operate and which patient can wait. So the neurosurgeons, for example, they suffer about that because they see patients which they want to operate. We have not the capacity to operate everyone.
Yeah, absolutely. I agree. Okay, I'll maybe invite Eva to share some experiences too before we wrap up.
So I will be quite brief because most aspects have been already touched. I, like Matthias, I also didn't participate directly in the COVID patients care, but we as endocrinologists were put in the second line services, like providing consulting care throughout all the hospital. So from that perspective, that was also quite scary initially in spring, because of course none of us knew what to expect, and if the people in COVID ward were still using some protective suits and personal protective equipment, we were kind of trying to see what could be available for us, and there was a bit constant fear of bringing or spreading the disease for the closest or for younger colleagues. On the other side, I think Latvia was in a bit specific situation because in our country, the first wave was very, very light, mild. We were one of the best doing in the spring. And that gave us a huge information load. So we could sort out what's happening in the other countries. So from the scientific way, we felt like we are well educated. But it unfortunately led us to a bit burnout, readiness burnout, when you are ready, expecting, and you're just burning out because nothing major happens then in spring. And what happens even a bit worse, that during the summer, everyone got relaxed because everyone started in our country to think that, okay, that's just a hoax, nothing will happen. And now, unfortunately, when I hear the Italy, Spain, other southern countries are probably dealing a bit easier, then we are getting quite a big amount of the work a bit unprepared. And the good thing is still that on the difference with spring, our oncology patients are still getting care a bit slightly delayed, but we try not to delete or postpone any planned or elective procedures for these patients. That's one thing. And the last from my perspective, very briefly, what we felt sometimes there was a bit shift in the leadership, because sometimes we unfortunately didn't see that the supposed to be leaders are stepping up and giving the proper communication with the others, with the medical staff and with the people, non-medical people. And now we are kind of paying a bit of the price of this lack of advocacy, lack of the proper support from the leadership as a sequela. That's from my perspective.
Interesting. I mean, I certainly recognize the feeling that having too much time to prepare sometimes can make it worse. I mean, I certainly in my team, I think the anxiety before the first wave really hit was at its highest. I think once we actually started to get stuck in, you're almost too busy to have too much time thinking about it. But yeah, it was maybe the most stressful period in a strange way. Interesting. I don't know if Hans has got any comments on that. I mean, there's certainly different kind of phases to the pandemic, aren't there, in terms of anxiety and how to cope with it.
yeah, too much stress and too low stress is even the same stressful. Yeah.
Mm.
And the difficulty was I guess sure that we didn't know where we prepare for.
Mm.
And but when I try to look to now, I guess that is still the matter. Now societies are hoping on the vaccine, and Britain has begun with it. But the next months will show how good they really are. So, but also that sharing that uncertainty also remains important, because we don't know how the next months will go.
Yeah, absolutely. Okay. So we are running out of time, and what I'll maybe ask Hans and Tiffany to do just to wrap up, I don't know if Hans would be willing to just maybe summarize the themes that he's identified from all the stories we've heard briefly, and then maybe from Tiffany some quick take-home messages about practical things that each of us can do to try and support and promote our well-being. Hans.
Yeah, I will thank you that I made talk so much, so I will take it very short now. Because I find your sentence, Frauke, one of the most important: build up trust. You build up trust with your colleagues, with your work environment, with patients and family. Because trust will help you to deal with uncertainty. And the second is to be very honest to yourself in the first thing. To just look also to your emotions, to your feelings. It is okay. But when you get the feeling, whoa, this is quite heavy, then it's good to talk about someone else, and it will lower that feeling. But also there, and because of that, I find your sentence at most important: build up trust, because sharing that feelings, they also need trust with your direct colleagues, and that you know that it's okay to also be vulnerable as a doctor.
Yeah, okay. Thank you. Tiffany.
Yeah. So, I mean, I think all of our panelists have offered some really sage advice here. I think there are just a few things I will come back to. One is take care of yourself. I mean, obviously, emotionally is one that, and psychologically is one that we've talked about a lot today. But taking care of yourself means physically and otherwise too, right? They seem like quite obvious things, but getting exercise, getting enough sleep, eating well and regularly, those are all important things. Really super basic, right? But really important to make sure that those are there for your reserves.
And easy to forget when you're stressed.
Yes, exactly. Eating lunch at your computer, or, not going to the bathroom for several hours, especially if you're wrapped up in full body PETE. Like, these are, physical health is important. We're not going to do the 7-minute workout, but another thing is just I think one of the things that I heard recently that I really like in terms of connecting and checking in with colleagues is this thing called a double tap, which is to say, you see a colleague, you maybe have sort of a feeling that maybe something is off, and you say, how are you doing? And, at least in American culture, how are you doing is used as a greeting. It's not always used as an opener to actually ask, how are you doing? So if in the event you encounter someone who just uses it to say, fine, okay, whatever, the double tap is to ask it again, to say, are you sure you're okay? Like, really, how are you? And I think that conveys that sense that we've talked about you being there and being willing to listen. So if you take that time to check in and really ask and listen, I think that really matters a lot. And if people are like, no, I'm totally fine, just leave me alone, that's totally fine. Then in that case, you've done your part. The last part I will say is what Eva mentioned to emphasize is the advocacy part.
Mm-hmm.
So, I mean, we can talk about all these individual things that you can do for yourself and within a team. But if you are in a position of leadership or a position where you can amplify the voices of others who have concerns about environmental situations, resource shortages, or other issues, you should use your voice and I think help to amplify the voices of others to be able to make important changes, whether that's a change in your department, your organization, or even at a policy level. It's incredibly important for physicians to have a role there, even though we don't like to be like, oh, medicine is, apolitical. That's not true, to be totally honest, in our current environment. Yeah. We have to step in, use our medical expertise to be able to make changes for the public.
Okay, thanks. I'll maybe finish off with one quick question from Maria that I can see in the Q&A box, maybe to Tiffany as well, if that's okay. So Maria is asking, do you think that seminars about how to manage stress and emotional concerns should be included in medicine career programs? I know what you're going to say, but I would still like to hear your answer, Tiffany.
So actually, I might suggest, once you get to the point where you're in medical school or medical training, we're pretty fully formed adults for the most part, aside from developing professional identity further. I would actually say the process probably needs to start earlier in life. In earlier education, where we learn emotional intelligence, cultural sensitivity, and adaptability. I mean, these are all universal skills that all people could benefit from. That being said, that's an ideal that would need to be advocated for. So that being said, I would say that because physicians are in a position of potential for secondary traumas, as Matthias had mentioned, and all these things that we've discussed, in the absence of having earlier life education for everyone about emotional intelligence, I think it is important for us to learn basic skills, but also recognize all the complexities and the various factors that play into this. So we can help each other, help make the system better, and ultimately provide better patient care.
Okay, great. Thank you so much. Please, Hans.
Yeah, on that question, I find from my work that, the focus of the question is now stress and emotional question. But I guess there are two other very important themes, and that are existential questions and grief. And to learn also as a doctor sorry that I say that, but to stay human, to get to stay in touch with the big human questions is I guess even the same important. You will have to deal with them very, very often. And listening to Tiffany, maybe we can't recognize stress by ourselves very good. So that's a big risk factor. So I think a second thing which is very important is build a body system. Just look for someone, for one colleague, for two colleagues, which will warn you when they see you react in a way which they are not used because they then can tell you. Yeah. Because on your own you will not see. And that body systems are you can find very good literature about it from military. They use it also in very stressful situations to protect each other, because we can't protect ourselves very good.
Yeah, thank you. I think that is really good advice and something quite practical that's hopefully all of us can do if you find a trusted colleague. I think we're going to have to wrap up at this point. I would like to thank all the panel for their contributions, for sharing openly, and of course, Tiffany and Hans for sharing their advice, their experience and their expertise. And I do hope that it was useful to the audience. If you want to put any final comments in the chat box, please do. And thank you so much for joining. Okay, have a good evening, everybody. Bye.
Thank you.
Thanks.